Today's topic is epidural blood patch for orthostatic headache. So this is somewhat a topic for our mixed medical fraternity. For anesthesiologists, because it is related to the epidural, which is very close to any anesthesiologist. For the neurologist and the physician, because their patient headache is not getting relieved with the medical enough management, whatever management they are doing. And for the pain physician point of view, it is somewhat different because they relieve the headache of patient at the same time headache of the neurologist also. So what it is exactly? So in last year, I came across 2 cases of this. I will start with one of these cases. The 34 years female having headache, which is severe thrombing and from occipital to frontal, which increases with the work and relieves with the rest. She took medication from the nearby GPs. It's not getting relieved. So consulted physician. They have given addition analgesics. So she was on many medications. Tablet Ultracet, paracetamol, tramadol, Powergesic, that means combination of diclopara, chlorhexazone, that is muscle relaxants, pregabalin. And the lady telling that the pain is not relieved and only relieves with the rest and increases the work. That means something is wrong. So she was also on a tricyclic antidepressant, that is amitriptyline. But still the headache persists. So the consultant neurologist after 1 month. So the neurologist find that this is an orthostatic headache, even though it's not classic. So he investigated, and on MRI, he found that there is a typical signs of SIH, that is spontaneous intracranial hypotension, without any obvious CSF leak. So he started on sumatriptan, caffeine, but still there is no relief. So he consulted me, can we do something else in this patient? Because in literature, there is a clear-cut role of epidural blood patch in this situation. So I told we can do it very easily. So I have given epidural blood patch to T10-11 level with 20 ml of autologous blood. So there is instant pain relief on temple. And after 6-month follow-up, also there is no headache, no medication, and MRI findings become normal, completely reversed. So this is actually an eye-opener for everybody, and very dramatic results of this epidural blood patch in SIH, that is spontaneous intracranial hypotension. So let us see what it is. So intracranial hypotension is the terminology. It's a neurological condition in which there is a CSF loss occurs, mainly because of the dural tears. And it could be because of anything. It could be because of trauma. It could be because of iatrogenic cause, like we know very commonly PDPH, post-dural puncture headache, that is after spinal epidural or any spinal surgery. But apart from these iatrogenic causes and the trauma, it is known as a spontaneous intracranial hypotension. It could be because of the spinal dural defects or rupture of meningeal diverticulum or CSF venous fistula. And it is not that uncommon. The diagnosis is not detected properly. So it is around 5 per 1 lakh patients, more in females and common in 4th and 5th decade of life. And it is somewhat seen in more incidences found in hereditary disorders of connective tissue like Marfan's, joint hypermobility syndromes, EAPD syndrome. Before moving actually to the pathology of this intracranial hypotension, we have to see some basic physiology about the CSF and the pressure. As we know that the CSF pressure in lying down position is up to 20 centimeter of water. So in lying down position, and total CSF is 150 ml. So when we get up, that means in upright posture, the CSF in the cranial vault, it reduces, and at lumbar level or sacral level, it increases, maybe up to 40, it doubles. And the relationship between the CSF pressure and the volume is exponential. Even 10 ml of CSF is withdrawn or CSF loss occurs, there is a decrease in the intracranial CSF pressure, maybe more than 40%. So it is a substantial decrease in the CSF pressure in upright position. And that is enough to start the headache. So causes of this SIH, that is spontaneous intracranial hypotension, are varied. And most common is the fragile meningeal diverticula associated with the nerve root sleeves. So there is an outpouching, that is a meningeal covering over the nerve roots, and there may be an outpouching may occur, and that diverticula may get rupture. Or because of the spur or calcification or from the disc protrusion can tear the dura. And there may be some fistula from CSF to venous fistula around it. You can see this. And these are few causes or main causes of the SIH. And common site which is found is in the thoracolumbar level, very less common in cervical region. And CSF loss from the cranial lesion because of trauma or anything does not cause SIH. So the leak from the spinal cord is the cause of the SIH and not the leak from the heart or cranial site. So this low CSF pressure causes a sagging of brain and associated structures. And there is a compensatory dilatation of the intracranial veins. So this is a Monro-Kelly hypothesis. The total volume inside the cranium and spinal canal remains constant. So if there is a CSF loss is there, that is get compensated by the increase in the intravascular volume. So there is a distension of the intracranial vessels. And both this leads to a pain. That is a sagging of this, a stretching of the pain sensitive areas, that is meninges. And also, along with that, the cranial nerve also gets stretched, pulls down. And because of that pulling, there will be subdural fluid collection occurs. And maybe sinus thrombosis can occur. A rupture of cortical veins occurs, and that may lead to a hematoma. And that is one of the common complication, that is subdural hematoma in SIH, that is intracranial hypotension. And if it is not treated, it can lead to a cerebral herniation and even deaths. Around 29 such cases are reported of death in SIH across the world till date, because few hundred cases till date they are reported of SIH. And in clinical features, very typical, there is a headache, and we know that PDPH headache is a postural headache. So more common it is occipital, but it could be frontal or diffuse, depending upon which part is getting stretched. More common is the cervical level is get stretched. That's why there is a occipital pain, and along with that there is a neck pain is also there. But in PDPH, we know that 15 minutes upright position should start the pain, and after 15 minutes lying down, the pain should get relieved. But it doesn't happen in SIH. This period is variable, maybe up to 2 hours or even more. And that is one of the reasons we fail to detect the orthostatic hypotension in SIH. But any orthostatic headache, that means the headache which increases with upright position and reduces with the lying down position, is considered to be the SIH until proved otherwise. And also it is associated with the nausea, vomiting, depending upon which part is get stretched and stimulated. There are various clinical features. The posterior neck pain and stiffness is also very common. Dizziness, the tinnitus, vertigo, because of the vestibulocochlear getting stretched. The diminished vision, photophobia, or a diplopia, blur vision, maybe because of the ophthalmic 6 cranial nerves get stretched. Decreased level of consciousness, yes, herniation also may be seen. And there is no precipitating factors like straining is seen always with in less than 50% of the patient, these precipitating factors are there, but it happens spontaneously major of the times. So if we find there is some if we feel that it is related to the SIH, then we investigate that patient, and on very typical signs are seen in MRI. This the diagnostic feature is the diffuse patchy enhancement, because there is a thickening of the dura and it becomes more reflective. So in MRI it is enhanced. There is venous engorgement, we can see brain sagging, the ventricles goes down, subdural fluid collection or hematoma, pituitary hyperemia or enlargement also can be detected on MRI. And to detect the exact site of CSF, there are myelography or CT radioisotopes are available. But whatever may be the advanced imaging is there, the exact site of CSF leak cannot be detected every time. It is less than 50% we detect or even less. So very typical triad is there to diagnose the SIH is the orthostatic headache, patchy meningeal enhancement on MRI, and low CSF opening pressure, because that is very much needed, because there are other causes are there, that is primary headache or subdural hemorrhage, and in hemorrhage also occur in SIH, but only subdural hemorrhage should be differentiated from the SIH with SDH. Carotid and vertebral artery dissection or post-traumatic headache or like that should be differentiated from the SIH with this triad. So in treatment, what is our goal is to stop the CSF leak and increase the CSF volume to maintain the CSF pressure. So initially, conservative treatment is offered. So bed rest, hydration. Hydration means please do not overhydrate that patient. If there is a underhydrated patient is there, that time you hydrate the patient. Caffeine, analgesics are given. Sumatriptans, as it causes vasoconstriction, as it is serotonin agonist, and this vasoconstriction of the dilated vessels will reduce the headache. Caffeine and theophylline has got some cerebral vasoconstriction action, as it is a phosphodiesterase inhibitor, and also it increases somewhat CSF production by stimulating the sodium potassium pump. So in both way it helps, caffeine and theophylline. So that is along with the hydration, caffeine is given all the time. Every time in PDPH we have seen. Pregabalin has got some role, and corticosteroid has got the unclear role, but many times it is given if the others fails. There are certain pain intervention also there, that is a greater occipital nerve block if there is a sarcogenic pain is there, or spinoparietal ganglion, as it is autonomic ganglion of the intracranial vessels, so it controls the vasoconstriction dilatation, and dilated intracranial vessels get constricted with this spinoparietal ganglion. You have to just put local anesthetics into the nose, or you can paint it, and that relieves headache. But most definitive way of management is the epidural blood patch for any refractory headaches, and that too moderate to severe. And that's why we have to assess the headache by visual scale and what it was previously and whether it is increasing over a period of time, even with the medical line of management. And if it is really moderate to severe and it is not responding to your medical line of management, which responds most of the time, 70-80% of the times, then only the epidural blood patch is indicated. What is the mechanism of action? It has got a mass effect. When we inject the blood into the epidural canal, it gives a pressure in the spinal compartment, and that shifts the CSF from the spinal compartment into the cranial compartment, and that traction is get reduced and the pain reduces. This is an immediate effect. And there is a epidural blood formation. The CSF and the blood interacts, and there is a coagulation occurs, and this coagulated blood seals. Also, there is some inflammatory changes occurs, and that helps to seal the defect till the natural integrity of the dura is maintained. So this is the dual effect. So there's a mass effect which shifts the CSF in a cranial wall and reduces the pressure immediately, and there is a slowly plug get formed at the seal. The success rate is really varying and depends upon multiple factors, whether you are given a targeted or a blind, or what is the patient's leak, where it is the leak actually, at lower side or at higher side or multiple side. Depending upon that, the success rate of this epidural blood patch is there, how much volume you are given, and you may require a repeat epidural blood patch 2 times, 3 times. We'll see later on this in detail. So how to do it? Like other epidural, but the consent, monitoring, and strict associated precautions is like other. Here, the antibiotic prophylaxis we give, because the infection is the most common side effects and very deleterious, and it is iatrogenic too. So the antibiotic prophylaxis, don't forget. Lateral position is given, painting dripping of back, and the dependent antecubital area is given. So I usually give left lateral position, so the left antecubital port is also painted dripping simultaneously, and the epidural space should be identified. The most important, this is a crucial phase. We are giving this to for the epidural tears, and if there is inadvertent dural puncture is there, so we should stop it, because that itself can worsen the situation. So if usually we loss of resistance to the air, many times we use to find out the epidural space, but if you use a saline, that is much better. That reduces the inadvertent dural punctures. At the same time, if you are really worried about this, you can use a fluoroscopy to prevent the dural puncture, because already there is intracranial hypotension is there. On the top of that, you again puncture the dura, there may be a precipitous fall in the intracranial pressure and maybe coning occurs. So this is a very dangerous thing which can occur if there is already herniation occurs, and if associated subdural hematoma is there, the coning and death can also occur. Then after locating, finding the epidural space, 20 ml of autologous blood is taken from the antecubital vein. I usually take in 10 and 10 ml syringe and slowly injected over a period of time, over a period of 1 minute, 1.5 minutes. I usually see 30-40 seconds per 10 ml, and we have to observe the back pain or radicular pain. And whenever there is a back pain or radicular, we have to stop it. That is actually a limiting factor. for total blood volume. And if don't fail any, if patient is not having any symptoms or no radiculopathy, then you can give completely 20 ml to the patient. And immediately after giving, patient is asked to remain supine for 2 hours and asked to not to do any straining for 6 weeks. So what are the complications of this? Headache, back pain, neck pain is a common complication, as common but self-limiting factor, a self-limiting complication of this, as it increases the intracranial pressure. Sometimes you may need some analgesic in a post-operative period, but it is self-limiting and it limits, it is within week it gets over. If it is happens, it is also rare. A radicular irritation by the blood, yes, it is there. Mild paralytic reaction can occur, but infection, beware of the infection. So strict aseptic precautions and antibiotic prophylaxis is must. And rarely there may be some adhesive arachnoiditis, subdural or spinal hematoma may be there. So the subdural puncture worsens the situation and beware of that. And this is the complication. But because of that complication, if you don't perform it or if it is untreated, the complications are even more. So this headache and back pain may become chronic, any chronic backache, chronic neck, and that actually deranges the quality of life. Lack of concentration, lack of working, and patient actually gives a long leave and remain home to avoid this. So this is very deleterious complication of not performing this procedure. Cranial subdural hematomas also is, if you don't perform, there is a constant low intracranial pressure and subdural hematoma is the commonest complication. Cerebral venous sinus thrombosis, cranial palsies, because there is a traction over that. Seizures can happen, and sometimes brainstem herniation and death also. So we have to perform, we have to treat it. So contraindication as usual for the any epidural, coagulation disorders, infection, febrile illness, septicemia, and if patient don't want. So let me share my 5 cases in short. First case I have discussed earlier. Second case, there's 25 years female, a recurrent severe orthostatic headache with nausea vomiting, and on imaging there is a SDH and signs of SIH, that is subdural hematoma and intracranial hypotension. Both findings were there, but we have not localized any leak. So in hospitalized patients, condition worsened. So we have done the bilateral craniotomy and the epidural lumbar blood patch in same city. And there is a significant improvement immediately, and there is no symptom after 6 months. In third case, this is a 1.5 months severe headache of to the 35 years male. MRI showed both again SDH and SIH. We have given thoracic epidural with that patient T1011, 20 ml, but there is no relief, just a transient relief. We have repeated it and we repeated the myelography, and we have found out that the leak is at cervical level. The rare one, but at cervical level, leak is there. But meanwhile, we lost the follow-up to that patient, and patient go to the Bombay, and there they get operated for the surgical repair of that. In fourth patient, there is a 1 month orthostatic hypotension with 38 meres. There is headache, MRI is same, intracranial hypertension. No leak we found here also. And we have given a lumbar epidural at L1, L2 level. And after 10 ml, patient has got a severe radiculopathy. There is a back pain. So we stopped after 10 ml. And the radicular symptoms treated with the pregabalin. There is headache markedly improved immediately after giving the injection. But even though MRI shows some recovery, after 6 months, the patient's complaint was still there, the headache was present. And even though some intensity is reduced, but headache was there. And also that patient gone to somewhere else when we lost the follow-up after that, but didn't turn up to us. In last case, 50 years male, 3 days post-dural headache, vomiting, and CT showed there is a bilateral SDH, and an MRI shows there is a SIH. So the bilateral mini craniotomy and the lumbar epidural blood patch was given with 20 ml of blood. There was a good symptomatic relief, developed seizure after that, and there's some transient speech disturbances. Might be because of some increased intracranial pressure, rebound intracranial pressures, which requires some treatment, that is anti-epileptic drugs. But patient fully recovered at 1 month and 6 month follow-up. Patient is absolutely fine. So in nutshell, in 5 cases, in 2 cases there is a bilateral craniotomy and the epidural blood patch was given, and both responded well. And one patient responded well, and another patient has got pain after 6 months. So in immediate pain relief is seen in 80% of the patient, and at 6 months, there is a 60% relief, the headache. So there is immediate relief. In nutshell, there is a result is 80%. There is immediate relief, sustained long-term relief in 60% of the patient. The radicular pain and paresthesia during injection limits the blood volume. A simultaneous craniotomy and the epidural blood patch in same setting is beneficial, and non-responders will require a further evaluation. We have to find out the leak, exact site of leak, and accordingly targeted epidural or surgical repair is needed. So while doing these cases, meanwhile I've gone through many literatures, and I found many literatures regarding this. But there are few hundred cases are reported till date about this, and I will share few which I liked and important for us. The factors predicting response to the first epidural blood patch in spontaneous intracranial hypotension. Here they have observed that there is good response which is found if the blood volume, if it is more than 22 ml, and CSF spinal leak is less than 8 segment. In MRI, you can see very well the segments, how much CSF leak is there. And midbrain Pounce angle, if it is more than 80 degree, then also if that means there is no engorgement of the Pounce, that means there is a good results. That means if it's less than 8 segment and good volume, there is a good 80% response. More than 88 segments CSF leak is there, and midbrain Pounce angle, if it is less than 40 degree, then there is also a response rate is reduced. Somebody has studied the lymphocyte, neutrophils lymphocyte ratio and platelet lymphocyte ratio. If it is less, then also they found it is poor response, because the action is also through the inflammatory response, and that seals the effect. And that's why if there is a low neutrophils and no platelets, then also there is a less response. Yes, for us there is a blind versus fluoroscopy guided. Fluoroscopy guided, we have to make the patient prone and you have to see the actually where the needle is going. But in iatrogenic IH, that means a PDPH patient, blind and fluoroscopy, there is no, if they observed no difference. But in spontaneous, there is some benefit with the fluoroscopy guidance, very little benefit over that. So if you do a blind with expert hand, there is no much difference between the fluoroscopy guided versus blind. Yes, a targeted versus non-targeted implant means we have to find out exact site where is the CSF leak is there, and then and there only we give the epidural blood patch, because that helps to seal. But for that we have to do the invasive imaging procedure. So it has been mentioned and it is recommended. This recent publication, June 2025, from the European Journal of Neurology, if patient had a SIH, so the first epidural should be blind, because there is no much difference between the first epidural blood patch results. And if it is not responding, then find out the cause with the invasive modality monitoring, and then give the targeted. So that's why our first epidural is blind and non-targeted. Do we really seal? They say that the immediate effect is because of the pressure effect, that is mass effect, and latter effect is because of the sealing of that. And they found that immediate effect is good, but over a period of time, the effect is reduced, because not every patient there is a leakage occurs, and because of that only the repeated 2-3 times epidural blood patch is recommended. In one of the study, it's only one case reported, that is a orthostatic headache, and they found it is a bilateral SDH is there. So they have done the emergency craniotomy, but after 5 days, that is 5th post-op day, there is a patient consciousness starts to reduce. There is headache. They have done a repeat CT. There is a pneumonitis, that is air, and there is a midline shift with the blood and air also there. There is a midline shift. MRI shows there is a CSF leak at T11, L2 level, and they have done the epidural blood patch with 18 ml of blood. So they have done this epidural blood patch after emergency craniotomy on the 5th day, and they found that there is all the deterioration slowly patient get improved, and at 14 days there is no headache, no hematoma is there in the cranial. There is a hematoma completely absorbed. So actually that is a SIH, and that should be treated simultaneously. There are few case report where they mentioned they have done simultaneously epidural blood patch and the craniotomy done simultaneously. Very rarely. This is also a recent journal from Japan, and the last year they have done one case of this subdural hematoma and SIH, and they have done simultaneously the epidural blood patch and the cranium. There are few cases, there is single case reports, and we have done 2 cases. I think they will add if I report it, and I'm going to report it shortly. This is also a single case report. This is from India, from Pune. This is a spontaneous intracranial hypotension was there, and they found exactly where is the site of leak. There is a cervical leak was there, and they have given a cervical epidural C71 with 8 ml of autologous, and there is immediate relief, and 10-month follow-up also there was no any symptom or headache. This is really wonderful case reporting. So in conclusion, the SIH is frequently underdiagnosed. So we have to maintain a high level of index of suspicion to detect the orthostatic headache. Epidural blood patch should be considered for moderate to severe orthostatic headache for SIH, which do not respond to the conservative management. Blind, non-targeted epidural blood patch at high thoracic and high lumbar or lower thoracic level, that is T10, 11 levels, is safe and effective. Craniotomy and epidural blood patch in same setting is effective in indicated patients. And radicular pain during injection can limit the delivery of the blood volume. And that is one of the criteria. If you give a less amount of blood epidurally, the chances of sealing of the leak is reduces. And untreated SIH may lead to a complication till death. And that's why we must treat this SIH with epidural blood patch to say no to headache. Thank you. And these are my references.